Ladies and gentlemen, let us start the last session of our conference. I have the honor of moderating this session. This session is about value, but value from the patient's perspective. In this section, we will hear voices about very different disciplines, from digitization through collecting data on the patient perspective in a systematic way, to the EU's plans concerning joint databases and digital spaces. The common denominator of this session is the patient perspective. If you were with us before the break, we had a great introduction to the focus of this session. During the previous session, we found out how differently we can understand value and how differently different groups of payers or stakeholders, such as service providers, medical professionals, and the national health funds perceive a value. I think the ethical rules are the uncharted territory of the Polish system. But as we heard in the lecture before the break, this is a very specific and concrete matter and influences the application of different diagnostic and treatment methods. Let me kick off this session for you because I am the first speaker according to the agenda. My presentation will be about the patient in the world of digitization. I hope my slides are up for you on the screen. I hope you can see them. Let me ask for some technical help. I'd like everyone to see it in the room and online, and let me start my presentation.
My presentation is to a large extent based on a report which I had the pleasure of developing along with my team, which included also Magda Włodysiuk and Kasia Kapcia, who is also present here, thanks to whom each report is also very aesthetic. The subject you can see, that is digitization of health in the public interest, indicates that we are not looking at digitization as a social progress, but also as a tool for a social change which can be used for different objectives. What we know very well right now is that digitization is a tool. It is a tool which inevitably changes the landscape in the healthcare system and how patients have interactions with the system, changes the way we practice medical professions, changes the role in which the payers look at how they can control service providers, but it also completely transforms the interactions of the patient and the healthcare system and the way how people can take care of their own health or how they can neglect their own health. So digitization opens a completely new social dimension of health determinants. We also have to factor in digital determinants, and their role will be increasing, and I think I will be able to present that in my short presentation. It applies to various dimensions. The obvious ones, like digital exclusion, elderly patients who are not proficient in digital use are experiencing a lot of problems with using new technologies. We will be referring that in Grażyna Cieślak's presentation, who will be presenting the local government program, which shows that using digital tools in the senior citizen population requires a lot of support on the part of flesh and blood assistants so that the digital technologies can actually be used. But it's not just about digital exclusion with regards to digital capacities, but also access to good quality internet can determine whether we can have access to medical treatment. So therefore, across Europe, we have postulated patient organizations which demand that good access to internet be considered a patient right. It's actually being quite an important issue. And from a different perspective as well, we are also facing with new forms of discrimination, which are created by data processing, particularly by AI algorithms. I will be talking about that in greater detail in a moment. And we are also facing such phenomena like acting to the detriment of our psychosocial health by the digital technologies, which is visible, for example, in the access of young men to the employment market. This is something I will be touching upon later on as well. So, digital health determinants are becoming also social determinants of the health, and we have to keep that in mind when we have our discussions in the Polish context, when we are talking about the patient's interest, about digitization. We are usually focusing on the lifestyle, and usually it's about specific choices, specific proposals which can help patients control their health. And there are fewer discussions about social conditions and, for example, postulates to provide generally accessible, good quality internet. So it's not always about the patient's individual competences, it's about a more broadly understood social policy. So the emphasis needs to be, for example, on general access to good quality internet. Otherwise, we will not be able to eradicate inequalities and introduce reliable, good, and fair digital technologies in health. We have had surveys showing that Poles love globalization and the so-called open market, and emphasis on personal responsibility. And maybe that is why we lack certain discussions about infrastructure which would help us avoid new forms of exclusion. On this slide, you can see the biggest trends that will revolutionize healthcare in 2024. According to the Forbes magazine, if you have a look at this list, you can see it's quite interesting because it involves two areas for health challenges. That is elderly care and prevention. All the other points are actually tools. So this mix of challenges and tools is very characteristic of the discussions about digitization in healthcare, along with the tendency to, instead of focusing on the objectives and specific solutions, we concentrate on the tools. So we don't know what we'll manage to achieve, but we always focus on, look at all the cool tools that we have. Also, in the case of digital tools, I guess it's a very is something that is covered heavily by the media. This does not foster a reliable discussion about the future of patients, because obviously digitization is a good tool. However, it needs to be used reliably and rationally. Otherwise, it increases inequality in healthcare. Because we have to factor in cognitive abilities of different people, and limitation in this regard can be addressed with well-selected digital tools, and poorly selected digital tools can increase the divide in the quality of healthcare, which is currently called the digital divide in healthcare. This is discussed by a British report, which you can see here on the slide. And they used an interesting research methodology. They recruited people from disadvantaged groups who then became the researchers. So they were sent out as surveyors. They carried out surveys among their community. So it was a less biased approach. And the effects of that study, a summary of that, you can see on that slide. I really encourage you read this report. It's a good read, an interesting approach. And what they found was that those groups identified problems which are usually marginalized. So most solutions, most tools are designed with bypassing disadvantaged groups. So they are designed by people living on a certain level, with a certain level of equipment, good internet, and high skills, with the bypassing of user experience of people who have a problem with digital competencies and infrastructure. And a lot of excluded people require the support of an actual person to use healthcare, and digitization increases the depersonalization of their experience. So it has an additional negative impact on their capacity of using the existing offer. So not only do they have a problem with using additional options, they have a problem with using what's already there. Additionally, in those groups, conflicting tendencies are quite visible. For example, exclusion due to ethnical origin. People like that are most concerned about providing their data, and also because of that, they are underrepresented in the data sets, which increases the problem even further. Very often, these are people with multimorbidity who would benefit most from such solutions. These are the people who would benefit most, and at the same time are subject to the greatest concerns and are most likely to opt out of the new questions, new issues, and opt out from providing their data. The NHS data example shows that although digitization can be a great tool supporting quality, in practice, in particular with groups which are at risk of exclusion, this is often also related to cost optimization. This is a threat. And the fact that considerations regarding common data sets, those new regulations, that is important, but in those major discussions, we lose track of what is most important for patients here and now. That is the use of digital tools to improve the quality of communication between a patient with his healthcare provider. So we are focusing on the bigger picture too much and too little decentralization of specific solution applicable to specific patients in specific communities. I think I have a few more minutes left. I will be focusing on a few specific issues. The first is how digitization increases the existing inequalities and how the use of AI can cause new templates for discrimination. So the fact that you all know that we are experiencing certain inequalities, and the introduction of new digital tools because of those social conditions increase those inequalities. So instead of improving the disadvantaged patient's situation, it decreases the situation even more. In particular, patients with some mobility disorders. So, for example, in Poland, the use of telehealth consultations for some patients, it might be a limitation. So, if a patient who is competent but doesn't speak will not use the telemedicine service. This can be dealt with, but there can be a solution for that. But someone in the healthcare system needs to notice this problem. If we don't have any fixes for that, then a solution which in theory is supposed to streamline help further increases exclusion. We see all that. We've seen that in Dutch experiments carried out on the social security sector. The studies showed that introduction of algorithms which were supposed to speed up the granting of various benefits or other forms of social support to the people in need proved to be more discriminatory than humans. Why was that? That's related with another problem, that's the using of biased data. So algorithms that are based on existing data led to discrimination of the algorithm because the data was skewed, it was biased. And a French example, a program used to establish the order of waiting times for healthcare, they would start determining the race and the origin of patients based on their surnames. They were automatically classified as no-shows, and they would have poorer access to scheduled appointments. So what we have in the data sets, if the data sets include any human biases, this can be augmented by AI. So the problem becomes even more intensified. It's also possible that AI might come up with discriminatory templates, which we might at first even miss and not notice. They can come up with new ways to discriminate. Hence, the postulate not to use the black box rule in healthcare, and that we should understand the reasons for taking specific decisions. We're talking about even simple interventions, not just complex ones. So this is still quite a developing topic when it comes to digital inequalities. That is the digital welfare and the capacity to use the digital world in a way which favors mental health and the possibilities of carrying out a person's professional development. We know that without digitization, class inequalities tend to replicate in subsequent generations. This is an old study from 1970, which shows how divergent the cognitive development of children is. So how poor children would become even less advantaged compared to children from higher classes over time. So the most talented children from poorer classes would perform much worse than even the poor performers or the less talented children from the higher classes. Obviously, there are many factors at play, but I just wanted to show you the mechanisms. If we don't have good general education, then we are facing a situation where a large group of citizens are deemed to have worse competencies. This results in health competencies, and this leads to an actual conclusion where a master's degree can impact a person's health capacity to take care of one's health. One last example. There are more and more studies which indicate that young men tend to choose the digital environment, in particular video games or internet games, as a pastime. And this is quite justified from the perspective of social economy, because they spend time in a pleasant way that way, and that makes people generally more happy than working to earn money. But something that was noticed in the context of the healthcare market, they tend to spend less time playing. And the latest studies, which you can find easily on the internet, have indicated that young women behave differently. They are more likely to read books rather than men, who tend to play more games and internet games. Most likely, this men's tendency to opt for the internet environment favors the creation of the incels. So involuntary celibate. So we can see that this impacts not just the professional employment market, but it impacts other social spheres, including the creation of new political trends. So this is an example of how the use of the digital area impacts the welfare of children and how it will impact the future chances of children. This has a large impact on healthcare in general and mental health in particular. And to sum up, I would like to say that, referring to the senior citizens, I now remember a presentation about interesting devices which monitor falls in elderly people. So we have some advanced solutions which send a signal that a senior citizen might have fallen, might have had a fall. It's a set of solutions which are supposed to keep the elderly person safe and healthy in their place of residence. We know it has implications for cost saving. We also know that cognitive deterioration is slower if a person stays in a place of residence that they know well. That's why, for example, in Dutch residence care homes, people are screened with photos from their youth, because it calms people down and fosters their cognitive functions. And if we think that now we want to close people with some digital armbands, which can be overly sensitive, by the way, we might come to the conclusion that in the case of elderly people, we will lead to an even greater pandemic of loneliness. And we know that loneliness is directly detrimental to the health status of people. Research proves that. In other words, to sum up, those three pillars of just healthcare system, so availability, equality, and fairness, all that can be supported by digital tools, but it requires one major assumption: that we not use the tools to optimize the costs of the systems, and that we measure closely the disadvantaged groups and follow them and factor them in. Otherwise, all those tools will backfire and they will increase the divide between the well-off, well-educated people from large cities and patients from smaller towns with lower education. And that will be it for me.
I think we'll leave the Q&A to the end of the session, unless someone has a question but has to leave urgently to catch their train. I don't see anyone with questions. If not, let's move on smoothly to the next presentation. Do we have Madam Ewa Bandurska, PhD, with us? From the Gdańsk Medical University. Yes, I'm here with you. Madam Bandurska specializes in PROMS. I won't take up her time, so I hand over to Madam Bandurska. Good afternoon. Thank you. And let me just say this is a great honor, but also an immense pleasure that I can participate in today's event. I would like to express my gratitude towards the organizers for extending an invitation to me. And let me congratulate them on the organization of a great event. Ladies and gentlemen, what I would like to present is an important topic, using patient-reported outcomes in assessing the effectiveness of care. We have to define cost effectiveness, and in order to do that, we have to adopt the right perspective. The right perspective on analyzing this issue. We all know what optimists are like, we all know what pessimists are like when we look at glass which is half full or half empty. An economist will always say a glass is half wasted. That's our approach. We always have to consider whether we have a more optimal way of exploiting the resources at hand. We have pharmacological and economic analyses to help us out. They help us assess the relation between the achieved outcomes and the costs which have been incurred in order to provide a given intervention. And if the scales are tipped towards effects, this gives us an initial green light for a given technology. However, what I want to focus on in this presentation is quite a lively discussion on what elements we need to take into account in our analyses and what role patient-reported outcomes should play in this analysis, how we could make use of them. Ladies and gentlemen, in accordance with the guidelines of the Polish HTA agency, we should use especially hard endpoints for HTA. We all are perfectly aware that hard endpoints are deaths, morbidity, health-related quality of life, and adverse events and effects divided into severe and non-severe ones. I think that we all know the levels of evidence pyramid, and we should exercise utmost caution when we take something from its base and not from its tip. We know the risk, but we are under pressure, under time pressure to introduce new technologies. This is a highly motivating factor for us. And the same goes for endpoints. We believe hard endpoints most. Still, we are aware that the patient voice on the effects of their own treatment may be key, may be most important. Therefore, it should be included in the analyses. What patient-reported endpoints do we discern? The first largest group are PROMs, patient-reported outcome measures, or reports on the current health condition of the patient, which come directly from the patient and are not interpreted in any way, are not altered in any way by a physician or other medical professional. So those are the feelings that a patient has about their own health condition. The other group of endpoints are patient-reported experience measures, PREMs in short. PREMs provide information about how patients perceive the healthcare received. They also provide information about the experiences or the emotions that the disease triggers in a patient. So two major groups, PROMs and PREMs. And I'll be telling you a story about these two groups, PROMs and PREMs. Why do we want to measure these endpoints? A couple of years ago, why did we arrive at the conclusion that they are important? I would like to show you two studies. There was quite a long time interval between them. The first study by Solberg et al. Was performed in 2001. This study evaluated the significance of 21 potentially important effectiveness indicators. There were three groups participating: physicians, patients, and patient families. If you look at the graph to the right, you can see how different these ratings are. They diverge in pain-related endpoints. The physicians rated the pain as less significant than patients, especially for abdominal pain and back pain. This indicates differences in perception, and these differences depend on the perspective adopted. The second study comes from 2019. It was performed by Rodriguez Gutierrez et al. The authors showed that the most commonly used effectiveness indicator for diabetes, HbA1c, is not significantly correlated with the effectiveness indicators that patients found important. So, for example, sight loss, and they were only correlated with surrogates, for example, nerve conduction. These two very important publications stirred up a discussion on which endpoints should be taken into account. and also a discussion where PROMs and PREMs should be located within these measures taken into account. Of course, we're not blindly trusting PROMs and PREMs, and we're not neglecting their disadvantages. The most important challenges and concerns connected with using PROMs and PREMs, well, the most important one is quality of data. We need validated questionnaires which will accurately and precisely measure anything that we want to measure. We have a lot of work ahead of us to create the right tools for analysis. We have gaps in technological infrastructure in Poland, which prevents us from systemic reporting on PROMs and PREMs. And as in any case, there's the human factor. People are not ready to introduce something new. Still, I would like to emphasize that available study results show that using PROMs and PREMs in the healthcare system increases patient satisfaction. It also helps build greater trust towards medical professionals. It also increases patient engagement, increases patient compliance. We witness improved self-control of the disease, and also communication is improved, communication between the physician and the patient, or a different HCP and the patient. This also translates into long-term positive health effects. One limiting factor that I can mention concerning PROMs and PREMs implementation and VBHC, value-based healthcare, is the lack of incentives that would be provided by decision makers to service providers. Service providers would have to invest a lot of time, effort, and resources to engage in reporting on these new indicators, on these new measures, and also engage in building a value understood in this sense. In order to show you that patient-reported endpoints are so important despite the challenges that I've mentioned, and we can use them in value-based healthcare. They can precede the development of the system. I would like to show you some studies on integrated care. This study comes from Gdańsk. This is what we are doing at my university. This is a value-based healthcare, value-based integrated care, or VBC. This is a publication where the objective was to show how the use of healthcare resources evolves, how it changes after patients are involved in integrated care. We adopted a more systemic approach to this analysis. We identified that we moved away from emergency care for patients involved in integrated care. There was a difference in the medical services used by patients. Patients more often used dental, physical therapy, ophthalmologist, and dermatology health services. This was a signal for us that the change in demand for healthcare services can serve as a surrogate endpoint for improving care for patients. That's the direction we took in our research. In the second publication, we analyzed integrated care specifically, and we analyzed its impact on demand for healthcare services. It turned out patients were hospitalized less frequently, we had less calls for ambulances, and more often they used their GP consultations. Undoubtedly, integrated care was much more cost-effective in counteracting adverse effects, especially hospitalizations connected with the primary disease of a patient, so COPD. In the case of this study, it was more effective than standard care. which patients used before integrated care. Let me present you with another publication. I think this is particularly important in my presentation, a literature review performed in 2021. This review analyzed the use of patient-reported endpoints in evaluating integrated care, in evaluating its effectiveness. To this end, a literature review was performed. It covered more than 10 years. It turned out that only in about half of the studies, at least one patient-reported outcome was used. In most cases, as I've shown you in the case of the previous publications, hard endpoints were used or endpoints connected with usage of the healthcare system. And PROMs and PREMs were not used so commonly. Certainly, there is no coherence in terms of selecting the tools for evaluating these endpoints. I mean surveys, questionnaires, and other analytical tools. More often, researchers used PROMs, so patient-reported outcomes, which help evaluate the health condition. For example, in the case of COPD, the physical mobility of patients, than PREMs, which evaluate the experience of patients. The usage of patient-centered endpoints is varied. There are places in the world where they are used much more often, and you can see that in the slide: the US, the Netherlands, the UK. In those countries, these patient-reported outcomes are recognized to a higher degree and visibly more often. We have 3 diseases in this literature review. Patient-reported outcomes were used for COPD, less frequently in depression, and even less frequently in treating diabetes and obesity. This is an important signal for us. Most probably, it reveals the absence of research tools, and I will refer to that in a moment. We're working hard in Gdańsk on increasing the pool of available tools. Our objective is to ensure that the absence of tools is no longer a hindrance in obtaining PROMs and PREMs. Moving on to the last publication, I've already mentioned the Gdańsk model of integrated care. It evolved from standard integrated care to value-based integrated care. That means it meets the criteria of systematic measurement of endpoints such as PROMs and PREMs in evaluating the effectiveness of our programs. In a study that we have recently published in this year, we showed not just how the model itself evolved, we also performed an analysis of the possibility of introducing similar models, of overcoming barriers, of introducing VBIC models in Poland. These challenges concerned all sides, the supply side, service providers who are afraid to enter into uncharted territory, and also on the side of the decision makers, the organizers. This side is not providing any important incentives, financial, reimbursement related, or any other that would help build potential for a VBIC implementation. And there's also the human factor. We have the human component as well. And by that I mean that people approach change by trying to fight it, counteract it. They're afraid of change. And of course, this is also of importance in this case. Ladies and gentlemen, I've already mentioned that we're not just complaining about the absence of tools, we're working on helping them emerge. It turns out that perceiving prompts and prems as valuable endpoints is so prevalent that they will not be phased out. But if they are to be developed, we need new research tools. We need tools that will actually measure whatever it is that we want to measure. We have published an article on psychometric analysis, the first disease-specific publication on validating PREMs. That's the PREM C9 questionnaire, which evaluates the functioning of patients with COPD. It also sums up their feelings about daily care, the services provided to them on a daily basis in the healthcare system. I would like to unequivocally and clearly state that patient-reported endpoints have never replaced other types of endpoints anywhere in the world, such as hard endpoints, which we are obliged to analyze. It was always an add-on. It was always something additional, some additional knowledge that we could acquire thanks to these patient-reported outcomes. It is always our objective to treat not results, not outcomes, but we want to treat patients. Therefore, patient-reported information, not analyzed, not transformed, not altered in any way by HCPs, are the information that could really help us in achieving this. Thank you, ladies and gentlemen. That's all from me. Thank you for your attention, and you're welcome to ask questions. You're also welcome to contact me if you're interested in this issue. Thank you very much for a wonderful presentation. We won't keep you here till the end of the session, so if you have any questions to Madam Bandurska, please ask them now. I can see we have the first question from our audience in the venue. Thank you very much. During the first session, we discussed our approach to uncertainty in HTA. Sorry if I'm repeating myself. I asked a similar question during the first session. We're talking about money. We're talking about ICERs, ISORs, ICURs. And where is the patient in all of this? Let me rephrase the question. How long do we have to wait until the patient perspective will be noticed in some way? To all those who haven't listened to the first session, let me just say that we heard answers such as, yes, we have patients to whom we talk to, we try to identify their needs, but we have some sort of committee, board, council who collect data on what patients need. But in HTA, this perspective is not really acknowledged. So a question to our speaker, how do you see this in the future? Is this achievable at all? Or are we at a very, very initial phase? Thank you so much for asking this question. Let me give you quite a tricky answer. I've been dealing with this issue for many years. I'm an expert in economic conditions, and I've been doing that since 2013. I already have some everyday observations about what is happening with patients, about how they're functioning, how they enter the whole process. It follows from my observations that there are many interesting interventions in Poland. We have a lot of interventions where people who are passionate about healthcare and understand the patient perspective, they understand the need to hear the patient out, are present in the system. But for many years, I've had the impression that these great interventions, that all of these actions are way ahead of the system by a couple of years. You've just asked me when will this be possible. I get the impression that I've already introduced this. If we will not keep working on this, if we will not be persistent, if we won't speak out loudly about the importance of the patient perspective, that it can't be, it's not replacing anything else, it's not undermining any other measures, that it's not conflicting with the functioning of current methods, then this can trigger some moves from the decision makers. I get the impression that the system is not responding. We have some single cases of implementation. We have some places where this is functioning, and it's been functioning for quite some time. They show us that it's possible, that it's feasible, but we don't have a holistic approach. And I really would like that to happen, and I hope for that to happen in the nearest future, that step by step we will see that happening, and I hope for that. Thank you. Thank you. Do we have any other questions from the room? If not, then I have a question. One thing that I find very important that has been said here is that we need validated tools. Validated tools for measuring PROMs and PREMs. Research and clinical centers have a major role to play in this area. They could provide the tools that would form the basis for new financing schemes. And coming back to the previous session and the conflict of values among patients themselves, I have another question. We don't have that problem yet because we're not measuring it, so I'm a bit ahead of the developments here, and we don't have financial rewards for good treatment of patients. But what can we do about these conflicts of values in patient groups? How can we deal with this by means of such measures? I think that what is crucial is the structure of a study. It is also crucial how these tools will be validated. We are well aware that there are differences in perceiving value within patient groups, between patient subgroups. This is very valuable information for us. This is going to help us prevent major errors of methodological errors. Let me just emphasize that building a new research tool means years of hard work. Such problems connected with differences between patient subgroups, with narrowing down a research tool for specific patient subgroups. Work on that is pending at the moment. Therefore, we must brace ourselves for a marathon, for covering a really long stretch. And on that way, we have to develop research tools in Poland, or the other option is to use research tools that are already present in other countries. I've mentioned PREM-C9, a questionnaire. That's the questionnaire we've just completed validation work on. This questionnaire has been developed in the UK. There's a lot of research tools of similar nature, and if they meet the right criteria, if they meet the right validation criteria, if their accuracy, reliability will be confirmed, then if we take into account the psychometric conditions in Poland and approve it for use, these can be helpful to us. That's the way this is structured. As concerns preparing research tools and creating questionnaires, well, this is a lot of hard work. It's very effort consuming. We really need to involve many research centers. We need people who will want to devote their time and effort to this very aspect, who will want to engage in building a capacity in this area. And after we create this potential, I believe it will be easier to push through certain changes in the entire system. Thank you so much. This was really a fantastic presentation on proms and prems. I think that inevitably proms and prems will become part of the healthcare system better sooner than later, because the experience of individual patients is indispensable and it is missing in our healthcare system. Thank you so much. And let's move on to the next presentation. We're still in Krakow, but still to a certain extent in Gdańsk. The next presentation will be delivered by Grażyna Cieślak, who works for the Gdańsk Center for Promoting Healthcare and Counteracting Addiction, and is also a member of the Polish Society of Healthcare in Gdańsk, and has quite a controversial title of her presentation. How can we repeat our success in diabetes prevention? So we will be talking about success.
Thank you so much for the opportunity to meet you. I would like to present you with an example of a prevention program, which actually is a pilot program. If I may refer to the previous presentation, it's one of the prevention programs developed for the Pomeranian province, developed by our Marshal Office, the Department of Health. So I would like to present you with the background, all of that. We have the healthcare policy programs, which was implemented by municipalities from the Pomeranian province across the province. As you might imagine, the program, the health policy program, is the basis, and each municipality had to find their own way of implementing it, of what is important to them, what tools they should use, using the information that is included in this framework program. It was a program financed from external funds, from the European Social Fund and from our operational fund for the Pomeranian province, and the municipality of the Gdańsk municipality budget, because we wanted to approach this implementation for the benefit of our citizens in a way which is patient-centered. And I think that it was a success, because the effects, in my opinion, are very promising, and that is why I would like to share them with you. The program ended just 10 days ago, on the 30th of September, but we knew that we want to collect data on how the program is carried out, so that we can use hard data to conclude what was the actual outcome of the program from the perspective of various stakeholders. So we have at our disposal various information on how this intervention, yearly intervention, impacted each patient in the program, and we have data of almost 700 people who successfully completed the support program. So our objective was exactly that, decreasing the incidence of type 2 diabetes of our citizens. So, as you can imagine, this is not an easy objective because it's about a behavioral change. It is not easy for the patients. It's not really about pharmaceuticals. It's not about treatment. It's about changing one's lifestyle. And we know this is not easy, especially maintaining such a change for a longer time horizon. So our target group were adults who, until the program, were not treated because of type 2 diabetes, and over the last year they did not carry out tests regarding their blood sugar levels. This program was implemented for 4 years actually, but from the perspective of patients it was 2.5 years of recruitment, because each patient had to have at least one recruitment year. The whole intervention took 1 year for specific patients. So we had to identify people with a prediabetes problem. Then we had to implement educational measures to provide those people with the knowledge on how they can modify their lifestyle and to reduce the risk factors of developing type 2 diabetes, so increasing physical activity, limiting or eliminating nutritional mistakes, and as a result, reduction of overweight or obesity. We had some indicators. The Find Risk survey that I will talk about later was filled out by 20,000 residents of Gdańsk. We have 300,000 adults in Gdańsk. 20,000 filled out the survey, which was the first screening tool where we were looking for people with the right with this problem. Find Risk is a simple survey. It was designed as an electronic survey available on a website, and here a reference to digital exclusion of certain patients. Obviously, we had cases where elderly citizens were not able to fill out this survey. But we, knowing that it's the first program like that, we decided that whenever problems appear, we will be solving those problems as we go. And hence, in situations where elderly people were not able to fill out the survey, they were provided with assistance of a patient assistant. How it happened, I will tell you in a moment. So 20,000 people filled out the survey, and of those 20,000, 3,400 were then filled out the qualification survey. It is a survey which determines the risk of developing type 2 diabetes using the score, the answers to certain questions regarding, for example, the age, BMI, nutritional behaviors, and other health behaviors, and also some family-related factors, for example, a history of diabetes in the family. And if the person scored 12 or more points on the scale, this person was found to be at risk of developing diabetes within the upcoming 10 years. A person like that was then referred to laboratory tests to carry out the blood sugar tests. We also included a glycemic test because this this test was sometimes burdensome for the patients. When the lab tests suggested diabetes or suggested a pre-diabetic condition, this was confirmed by the doctor. So at first we had adult people who were 45 years or older who have not been diagnosed with diabetes. These people would this was the first screening stage, and then we would qualify patients on the basis of the glucose tolerance test. If the person was found to be in a pre-diabetic state, they were referred to a nurse and medical consultation. Then the people were taught about their current health condition, about what that person should do, so that that person is informed about what they should do to avoid developing diabetes. This was planned as a group workshop, but as you can see, the program was implemented in 2019, actually 2020. So that was the time of the coronavirus pandemic, which unfortunately excluded such face-to-face meetings. So we replaced that with webinars. They were very specialized, very effective 4-hour webinars with lecturers done by physicians, by dietitians, by physical exercise coaches, and a psychologist. They were available to everyone who opted in. We would organize that in at a time which was convenient for people, that is on Saturdays. And still we identified a problem. A lot of people that do not want to take part in the program because they think they don't have the time for such training. So we decided, okay, for people like that who have it difficult to find the time, we will prepare an e-learning training using the fact that during the oral glucose tolerance test, the person spends 2 hours at the laboratory. So we bought tablets and we prepared an e-learning for those people who otherwise said they would not find the time for the workshop, so that they get the knowledge that way. Then each person was provided with individual meetings. A meeting with a personal coach and 3 meetings with a dietitian. And at the end, we also carried out a training at the end. I also wanted to mention that using the tablets, we tried the people to take a test. We tested their knowledge on good nutrition and on physical activity. So all the problems that are important for introducing a change in one's lifestyle, because people should be convinced that is necessary. So at the end, we also carried out tests like that to see whether after 1 year of educating people, because this education was performed by the coaches, by the dietitians, we verified that. We verified this potential progress, and we also have results not just for the baseline, but also at the end of the project. So we collected all that data along the way. Every person had a full record of their participation in the project. After the training, they were again referred to laboratory tests to have hard data on the effects of our intervention. to see whether we managed to reduce this risk of incidents. Then the patient also was referred to an appointment with a nurse where all anthropomorphic measurements were carried out. And that was concluded with an appointment with a physician so that that person would receive instructions for the future. At the end, we also asked the patients, the participants, to fill out a survey, a satisfaction survey. These were paper surveys. So we did a collation of all the results of the paper surveys, and we know what the marks we received. Before that, each patient also received an assistant who, in the case of any trouble with participating in the program, was there to help them. Even if it was simple clicking along the workshop or the survey, because indeed there were a lot of people who required this type of assistance. As you might know, prediabetes is often the problem of elderly people, and we really did not want to exclude this demographic group. Furthermore, some elderly people don't have a cell phone, which we used to communicate with them. They don't have an email address, and we assumed that some educational materials would be sent in electronic version via email to save the costs on the paper. However, it was not always possible. We also used our website. You can see a screen like that on the slide, where the first screening was fill out the find risk survey. That was an electronic survey. We wanted to have those results because some of the questions and answers to them were particularly important, and we felt they might prove to be very useful in assessing this intervention in the future. So we also have that data in electronic form. So a patient would fill out the survey on our website, or alternatively, they could come to this education point where they were welcome to come to all the appointments. So, like I said, there was either an online version or it turned out that even despite the coronavirus, most participants preferred face-to-face meetings. Indeed, the fact that we planned this program for a year which turned out to be the pandemic year, that was a big hurdle for us. People were afraid of coming in person, and all the services were provided by the Medicover Foundation in the Medicover facilities. It was a place which the participants said they enjoyed visiting, and we also offered them with this facilitation. There were as many as 4 different laboratories where the patients could take their lab tests, and the appointments were scheduled in line with the preferences of the participants, Saturdays included. So we tried to be as patient-friendly as possible, to do everything we can so that the dropout rate would be as low as possible. As already mentioned, we started with education. It took different forms, initial and completion trainings, which were there to make sure they get the knowledge. These are brochures and leaflets that were available in electronic form, and when they finished when they completed their find risk survey, they were asked to provide us with their phone number and email address, so that we can invite them to the meetings. And we prepared those brochures for the participants to share with others. And our participants also received the support in the form of a mobile application, provided that the people had the cell phone, where they could use trainings and then they would discuss their trainings with those personal coaches that we provided. They also received a journal, which was there to indicate to write down the dates of all appointments, to indicate the progress, the results. This helped verify whether the assumed objectives have been met. It turned out that they did the trick. They were particularly enjoyed by people who were closer to 50 years maybe, or in later decades. So the older the people, the more they enjoyed filling out that journal. We also provided them with a guidebook. It had more than 50 pages, and it would bring together general knowledge, which turned out not to be that obvious in those pre-diabetic people. And now a little data so that you can see the scale of the project. Because in a moment I will move on to the other studies. So we performed 3.5 oral glucose tolerance tests. There were a lot of specialist consultations. All that was financed for the participants. And what were the results? Of all the people who, in line with the lab tests, we had we had 2,319 healthy people, 908 people in pre-diabetic status, and 142 people with suspected diabetes who did not assume they had diabetes. First of all, we were surprised by how many people of the 3,500, how many of those people were pre-diabetic. We assumed that the percentage of people at risk of developing a full-blown diabetes, we thought there would be fewer people. We don't know whether it was because of the coronavirus, whether it was a bias, or whether it was the result of sedentary life caused by the pandemic. Either way, this scale of the problem surprised us, and myself as the coordinator started calculating the costs, because we had to the more people we included in the program, the more visits we had to finance. So we had to make adjustments to our budget. So that's a logistical remark. So what was the volume of people? So you can see how many people were qualified for the program. 871 people. And for the 12 months, the program was successfully completed by 706 people. We were quite surprised. We were afraid that the dropout rate would be greater. It's difficult in long-term projects. And yet, you can see that most people stayed with us until the end, and it is the best testimony for Medicover, who supported us in this. So we had weekly meetings with our subcontractors. All the problems were solved as we go, which resulted in a situation where the patient's concerns or problems were addressed immediately. We really would take necessary decisions immediately. As you know, this project was co-financed by the EU funds, and This is associated with the need for detailed reporting. And this is the result which we also found surprising. So 341 people of the 706 people, according to the laboratory data, managed to fix their pre-diabetic state and no longer were at risk of diabetes. So was a very positive surprise for us. We do consider it to be a big success because that's what we wanted. We wanted this pre-diabetic stage to retreat to make those people healthy. I don't know how long-lasting the result will be. The program ended just 10 days ago. It would be good to return to those people. We know that pre-diabetes is not something that will go away once for good. If those people fail to maintain their healthy habits, pre-diabetes might return. What were the opinions of the participants? They were very positive. We met with everyone involved in the project to see what worked well, what required some improvement, what could be done better in the future. And we are really happy with the results of these satisfaction surveys. You can see that over 80% of our participants were very enthusiastic. So thank you for bearing with me. And if you have any questions, please do not hesitate to ask.
Thank you so much. This is incredible. The maintenance of the level of the program and also the effects of the program. It also shows that personal involvement translates into health outcomes. This phenomenon has been studied and confirmed. In reference to what already has been said, it's important to ensure complementarity of digital solutions and the human factor. Do you have questions now, or would you like to ask them at the end of this session? There's a question that will come at the end of the session. If I may just add something about digital exclusion. We tried to introduce the program so as to provide many different digital solutions. It makes it easier for us to implement a program. Still, we tried not to leave out those patients who don't have such access. We didn't want them to miss out on the program, and we had a special supervisor of the program who was a patient. This really worked. That was his digital prosthetics. This really impressed me. We always think everyone must have a smartphone or a mobile phone, but that's not the case. We'll leave the questions until the end, and before we have the discussion, let me hand over to our last speaker of this session and the whole conference, Michał Chodorek, advocate, who will give us the patient perspective on one of the most important EU initiatives, that is European Health Data Space. In particular, he will discuss data use from the patient perspective. Ladies and gentlemen, good afternoon. Thank you. European Health Data Space is probably the biggest revolution in access to medical data and the possibility of using health data from the establishment of the European Union. We always discuss EHDS from different perspectives, from the academic perspective, the scientific perspective, public stakeholders, business. The patient perspective is also very significant. Therefore, it's worth adopting the patient perspective on EHDS and try thinking of what questions patients have about EHDS. If we don't have the right levels of public trust, then the whole project will be at grave risk of failure in the long or short run. Therefore, the public perspective is so crucial. I think that the designers of EHDS are well aware of this. When we look at the assumptions, when we look at the problems that triggered the development of EHDS, we can see that the designers pointed to difficulties in accessing health medical data by service providers, by exchanging these data to ensure continuity of healthcare and also to improve healthcare quality. We can also see problems with transparent and easy access and insight into those data. And it was identified that this impacted the quality of healthcare for EU citizens. This impacts everything: access to pharmaceuticals, to drug therapies. Another problem that was identified was the absence of possibilities to readily manage one's own personal data and medical data. In any cases that we use patient data for R&D purposes, we must respect the rights of privacy. EHDS wants to address and resolve all of these problems. Once again, the EU has listed that in the regulation on the EHDS. It's worth adopting two perspectives when looking at the regulation. We can look at it in technical terms of the infrastructure where EHDS be run, and also the whole operational perspective. So the first one, the technical infrastructure, is a very ambitious project because all service providers across the EU are to be connected with their national contact points. The national contact points will be connected with all other national contact points by means of European data transmission infrastructure. That means every single European service provider will be connected with other European service providers through the central EU infrastructure, that is, the national contact points. On the one hand, this will make it possible to transfer data between service providers in order to provide health services. It will also reduce the costs of data transmission, and it will make communication easier. This infrastructure will cover not just service providers, but also biobanks, public bodies operating in healthcare. In Poland, that will be the National Health Fund that will have to be connected with EHDS. For example, SMTP will have to be connected with EHDS. This will be based on the Polish law on the protection of health data in medical databases, and all of those will be also connected to EHDS. We will have a very broad integration of different healthcare systems and different healthcare databases. Right now, they're operating separately. There's no communication between many of these systems. We don't have direct communication between service providers, and we have absolutely no communication between service providers from different countries. This infrastructure will be a revolution in this area. A very important component of the project is its regulatory basis. When we adopt the patient perspective on this, on the regulations, we will find something interesting, that is the secondary use of data. I think that's the biggest revolution, something that we haven't witnessed to date, for a couple of reasons. Coming back to the tech infrastructure and all the variables I've listed, led to a situation that actual access to health data was low for purposes other than health service provision. On the other hand, in many EU member states, we have fragmented regulations on data access. Poland is a good example in case we have laws on patient rights as concerns access to medical data. We have exceptions for universities and research institutes. We have separate regulations on IT access to medical data. The situation of biobanks is different. They have different rights of access to medical data, and secondary use of data from clinical studies and research trials is is also different. So we have different access rights to data from different sources. We also have uneven practice of using the resources we have at hand. If we want to use SMTP data, then depending to which voivodeship we submit our application to, we will either receive access or not, because every voivodeship has its own practice. This decreases transparency and elevates costs for conducting research activity. The cost of obtaining data for any scientific or research project is a significant part of every budget of a project that requires such data. And this translates into what I said in the introduction, delayed access to drug and non-drug technologies. And this means that only the biggest players can afford paying for access to data. We don't have a level playing field. Only those who are big players have enough resources or know how to get to the data can benefit from them. And the European Union wants to address this problem of uneven access. The EU wants to introduce harmonized, uniform and simplified rules of access. It wants to simplify access from the regulatory side, so simplify the criteria that we have to meet to get access, and also the EU wants to simplify the practical side of gaining access. All aspects will focus on a one-stop shop approach provided by the EU data space. The whole process is to be streamlined. If I want to use the data for R&D activity as part of secondary use of data, which means every instance of using data for purposes other than providing medical services, then I will have to go through this procedure I showed in the slide. Everyone who tried to obtain such data for R&D knows how revolutionary this slide is. The procedure will be as follows. The applicant who wants to gain access for, as part of secondary use submits an application for access. The national contact point, there will be one in every country. We won't have a dispersion of these bodies. The application is submitted to the national contact point. There's one per country. Important note, as a Polish researcher, scientist, Polish startup or Polish university who wants to create a new medical product can submit an application to any country in the EU. We can submit our application in Poland, in Germany, or in Finland, any EU member state. Wherever we submit our application, we can obtain data from across the EU, a quantum leap, an incredible progress. If our contact point decides that we meet the criteria, the application is correct and meets all the requirements, we will be granted access to data, and we will have specific conditions for using the data, defining what type of data we can use and the scope of that data. Then the national contact point compiles and aggregates the data to make them available to us. The national contact point will collect the data from data holders, from bodies also across the European Union, from other member states. And they will create one data set for us to work on. This is an incredible change, an incredible improvement as compared to the current situation. And then the national contact point makes the data available to us. Even in brief, even if we start thinking this might be a risk due to the fact that patient data is being made available, we can see that there are so many safeguards in this system. Firstly, we have one contact point that protects patient rights because we have a uniform practice concerning data access. Then, another safeguard: data is made available only to the scope defined in the application. Another important thing: we can't change the data. As an applicant, we can use the data only for the specific purpose stated in the application. If we want to change that purpose, we need to submit another application. I think this is a very good solution which provides patients with safety. Another important element, I think maybe the most important of them all: the application does not receive a copy of the data. The data is made available in the environment of the body making them available. So as users, we get access to an environment managed by the national contact point, and we will work on the data in that environment. If we want to train a machine learning algorithm, then all of that will happen in the access body environment. This is connected with the fact that we can't change the purpose of using the data. The environment will check if we're not changing that purpose. The national contact point will see what is happening with the data, and they can verify whether we're sticking to the requirements applicable. The whole environment ensures the highest safety of patient data. Irrespective of what I've just said, that secondary use will be possible for both public universities and research institutes, and it will be expanded to private entities, for example, startups which develop new health technologies. What is also important from the patient perspective: the purpose of secondary use of data. It will not be possible to use data for any purpose. There's a closed list of purposes for which we can use the data. Let me give you some examples. Any actions connected with the public interests in the area of public health, for example, ensuring high quality of medical services, ensuring quality and safety of pharmaceuticals and medical devices, pursuing educational activity in healthcare, scientific research in healthcare. So there's a finite list of purposes that we can pursue. There are also some prohibited purpose of using the data. That's an additional safeguard for patients. There's a list of purposes for which we cannot use the data. For example, we can't use the data to take any decisions that are detrimental to the individual. The data cannot be used to exclude anyone from an insurance policy or to change the insurance premium amounts. Those are just a couple of examples of prohibited purposes. The goal is to safeguard patients, to make sure that these data are used to an applicable purpose, so that down the line we're not using the data to the detriment of individual patients and European Union member states.
Jeszcze patrząc na to z perspektywy pacjenta, od kogo mogą pochodzić nasze dane?
Another thing about the patient perspective, where can the data come from? We have a catalogue, a list of data holders. Those will not just be service providers, but also biobanks, research institutions, scientific institutions, universities. Of course, if they have any data sets at hand, and public bodies as well. Coming to the end of this crash course on the patient perspectives on the EHDS, and taking a step back to looking at how the data will be made available. They will be made available not just in a secure processing environment of the national contact point. In general, the data will be anonymized. By default, the data will be anonymous. Should some project need pseudonymized, encoded data, this is possible, but the applicant has to provide sufficient grounds for using encoded data. And even if that is the case, then there are no specific identification numbers, so that we cannot identify the individual patients. The data users will not be capable of using those identification numbers to identify individual patients. Another important thing is that the data is made available for a specific period of time. By default, that's 5 years. The project can be extended by 5 years at most, and that's the end of it. That's when the data set will be erased by the access body. What will be retained is the algorithm used to access the data. If after those 5 or 10 years we have some proceedings about the compliance of our medical design, about the effectiveness of our medical device, then if we need to prove that the data we used to assess our health technology and to prove that we met some quality criteria, then it will be possible to reproduce those data, because the data set will be retained and the algorithms will be retained, but it will not be retained forever. It's important to bear that in mind. That's also a safeguard to the benefit of patients to prevent data leaks. Irrespective of the whole secondary use mechanism that I've just discussed, I think it's worth mentioning that the EHDS regulation itself also governs patient rights, irrespective of whether the data are subject to secondary use. So EHDS is supposed to provide additional patient rights. For example, the regulation will specify the right of access to electronic medical records. This is nothing new in Poland. We have such provisions in our laws on patient rights. However, the technical aspect will be crucial here. The European health data space will potentially simplify access in technical terms for patients. Patients will also acquire a wide range of other rights connected with their medical records, and they can enforce them from all service providers. So the regulation strengthens patients' rights. And patients have those rights irrespective of whether their data are subjected to secondary use or not. Thank you. That's more or less it. That's more or less the patient perspective on EHDS.
It was definitely a very concise crash course from a difficult topic, so thank you so much for that. And now it's time for any questions that might come up. Yes, I do have a question to finish up. One question towards everyone in this session. Maybe I will let Maria off the hook, but otherwise, with regard to the pre-diabetes program, I understand you're still at the stage of analyzing your data, so you might not have all the results. But have you outside from checking the whether there is diabetes or not, you probably took into account, you measured the weight and other factors. Yes, because of time constraints, I didn't mention everything, but we developed procedures for all of our specialists where they were obliged to collect all that data, and we have that data for each patient changing over time. It's a huge database, and now we're just starting to evaluate that data. So first we have to decide which of that data will be analyzed by us and which we find to be the most important ones. And we do have that data. So do you plan to return to the same patients and check whether they are continuing their good habits? Yes, we have the consent of those participants to contact them with regard to the project. So in theory, this consent applies only as long as the project is in force. We'll probably be asking them via email for consent to follow up on the topic. After, let's say, a year, we'd like to establish what the situation is, whether they manage to maintain their habits, whether they performed any lab tests, if they have any evidence. We could also maybe suggest tests sponsored for them. So we will think about it, but it will be decided based on our evaluation of the program as a whole. Obviously, this is also dependent on the funding that we will have at our disposal, but this is something we would like to do because this is the type of intervention which will be successful if the patients, if the participants manage to wane off the possible diabetes for a long time so that the change is long-lasting. So I'm quite anxious to see the results. That's a huge patient population, especially given the pre-diabetes studies. We have too few of those. In particular, with regards to prevention interventions, we rarely have the chance to assess the efficacy, so I am counting on the conclusions. Coming back to patient rights, so do I have the right to refuse the feeding of my data to the European health database, even if they are available in Poland? And if anyone consents, let's say in some laboratory, if I consent to a study, if I go there to, let's say, have my blood tested, can that laboratory use that data for any other purposes other than testing my health? Starting with the first question. Currently, as the project looks like, we don't have an opt-in version, so the secondary use is not dependent on opting in, on giving consent, and we also don't have an opt-out version. So my rejection will not block this possibility will not limit this possibility. We hear voices that there should be an opt-out option. Creating this option would probably be associated with the risk that we would observe erosion of the available database, because we would come across some objections in the public discussions. In Poland, we had a good example of the pregnancy registry. The social response was very negative regarding the creation of such a register, even though from the point of view of the health interest of pregnant women, this idea was to address the existing problems. But because the level of trust was so low, in this, the public reception was very negative. So if we had an opt-out, each situation like that would result in groups of people opt-outing from this initiative. That regarding the first part. When it comes to your second question, is the healthcare provider, in this case a diagnostic laboratory, can they use data collected as part of the test for other purposes without my knowledge or consent? Then no, absolutely. For that data to be used for other purposes rather than provision of a healthcare service, they need to either get my consent so that I am aware of that possibility as I consent to the service. And in a different situation, you can take data from the electronic record, and we can anonymize that data. This option in Poland is already available, and let's say universities or research facilities have access to such data. However, data which does not allow for specific identification of the patient. So these are the only options here. So if our trust towards the EU drops, then we will be facing a problem. If I can also ask about the scheme of transferring the data to the EU. You mentioned that healthcare practitioners are contacting one another. My question is, can the patient... So the patient should consent to that, because that was the idea of P1. The data collected on the patient's account could be made available to a healthcare facility, but only if the patient consented to it. I don't know what the current situation is, but around 2015, when that was being designed, the idea was that the patient needs to consent to a different facility using that data collected from their facility. So there are two issues. The patient can consent to that, but the healthcare facility can also receive access to that data. And this applies to specific patients without an informed consent. This can be done for the purpose of continuity of healthcare service provision. So yes, the purpose is continuity of healthcare service provision, but practically we will always be talking about this continuity, because the patient comes to me, to a different healthcare facility, and they have to consent to receiving services. So it not be like that the doctor... So the cases can be quite complex. Let's say the patient is unconscious. Let's say, okay, we have, let's say, an unconscious patient in Italy. I can't imagine that every doctor, every healthcare professional, and an EU country will have access to, will be accessing specific patients' data. So I understand that if we'll probably be using the access bodies who will be supporting these processes. That's how I understand it. So the infrastructure will be created to allow access to such medical records. I imagine that the first idea is the summary, followed by some summing up of specific stages of treatment. This is the question of the user's interface, who will have to have access to be able to provide services, and also we can consider it a technicality, a technical issue. We are right now not at the stage of creating technical solutions and national databases. When we are at that stage, we should definitely address that issue, because this is a technical issue. So, without doubt, we'll have this hierarchy of search criteria. We'll be using probably private patients identifiers as well. The first level of hierarchy will be the nationality of the patient, so that we will know which national contact point we should address to obtain access to the data. So I'm looking forward into the future, but from the perspective of the user's interface, it's not like the healthcare provider will have to search for a specific facility. The rest information will be there in the back end, and the system will streamline it from the perspective of the doctor who needs access to the data, but he can't serve as a researcher searching for the right institution. That would be an unnecessary complication. So also from the perspective of communication between Polish healthcare providers, this would cut out some administrative work on the part of hospitals. It would streamline cooperation and communication. So when we look at the report, we can see that we have information whether each healthcare facility has access to a computer and all that. But later on in the report, we have information about how data is made available. In 90%, it is done in paper version or electronically, but on a specific medium. And only a few percent of facilities actually exchange data electronically. So this is something that still requires a lot of work. I have one more question. If we still have Ms. Bandurska. Oh, she disconnected. That's a pity. So I ran out of questions. In that case, I think we can close up this incredibly interesting session and ask Magdalena to finish and conclude our whole symposium. So stay with me, bear with me until the end. Ladies and gentlemen, I would like to thank everyone for staying with us until the very end. Thank you to the interpreters for staying with us. I've managed to listen to the first session. Thank you for this reliable work and the smiling during the translating. Thank you to all the listeners, to everyone thinking, everyone taking part. I hope you come back to us next year. I hope it will be as interesting as this year, and we'll have as many interesting topics as we did this year. Thank you to all the organizers, to all the people who supported us, both financially and mentally. So thank you to all the sponsors. Thank you to all of you, and I would like to invite you for next year's session.